بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. I am Dr. Yasser Abul Futuh Al-Hinidi, Professor of Neurology, Faculty of Medicine, Tanta University. I will talk with you about the infectious diseases of the infectious diseases of the central nervous system may affect the meninges covering the brain and the spinal cord, which is called the meningitis, which is usually bacterial. The infections of the central nervous system may affect the brain parenchyma itself, that's called encephalitis, and when it affects the parenchymal tissue of the spinal cord with the brain, that's called encephalomyelitis. The third type of the infectious diseases of the central nervous system is the localized infections of the brain tissue or brain parenchyma with subsequent liquefactive necrosis in the central of the inflamed area and the capsule formation around it is called the brain abscess. The first type of the CNS infection is the meningitis. And meningitis mean inflammations of the meninges covering the central nervous system, including the dura, arachnoid, and pia maters. The inflammations of the dura, which is rare, is known as pachymeningitis, while the inflammations of the pia-arachnoid matter is more common, and it's called leptomeningitis. This leptomeningitis can be classified into bacterial meningitis, viral meningitis, and spirochetal meningitis. The bacterial meningitis may be pyogenic, caused by pyogenic organisms, including meningococcal meningitis, which is the most common form of bacterial meningitis. Also, it may be caused by pneumococcal infection, streptococcal infections, and the Haemophilus influenza. The second type of bacterial meningitis is tuberculous meningitis. The meningococcal meningitis, the etiology of it, when we talk about the etiology, we talk about the causative organism and the mode of infection with subsequent pathological changes after the transmissions of infections. The causative organism of the meningococcal meningitis is the meningococci, which is a kidney-shaped gram-negative diplococci. This organism is transmitted from the patients or the carriers of the organism to the other person by droplet infection. The organisms are implanted in the nasopharynx of the new host and then invade the blood, making bacteremia to reach the meninges via the choroid plexus. The incubation period is usually 4 days. The disease may occur sporadically or in epidemic, attacking the children and young adults. The clinical pictures of the meningococcal meningitis. The disease usually passes into 2 stages. The septicemic stage, and it's manifested by acute onset, a triad of fever, headache, and vomiting. The onset is frequently associated with rigor in children and convulsions in adults. The patient shows fever and the temperature is high, usually 39 up to 40 degrees centigrade. With drowsiness, skin rash may appear. This stage remains about 2 days. Then the patient passes into the meningitic stage when the signs of meningeal irritations and the signs of increased intracranial tensions appear. This stage is manifested by severe headache with generalized pains, irritability, photophobia, and hypersensitivity. The patient tends to lie in an attitude of flexion, away from the light, and resist any manipulations. The temperature is high with tachycardia. Mental state is cloudy. In this stage, the signs of meningeal irritations appears, including neck rigidity, neck retractions, Kernig signs, and positive Brodzinski sign. Neck rigidity means passive flexions of the neck is difficult and painful. Neck retractions may occur and may be very severe, causing obsotonus. The Kernig sign means inability to extend the leg while the thigh is at a right angle to the abdomen. Positive Brodzinski sign, it means passive flexions of the neck will result in flexions of the lower limbs, and the flexions of one lower limb leads to flexions of the other lower limb. Rarely the cranial nerves are affected in the case of meningococcal meningitis. The motor system shows general weakness and the tremors may occur. The reflexes are diminished due to increased intracranial tension and inflammations of the roots. The plantar reflex usually flexor, sphincteric disturbances may occur, and finally, the sensory system show generalized hypersensitivity. The course of the meningococcal meningitis is variable. In untreated cases, the picture remains for 1 to 3 weeks. The patient either recovers gradually or gets worse and dies. With adequate therapy, recovery usually occurs within few days. The meningitis sometimes acute, fulminant, and fatal, what's called Waterhouse-Friedreichson syndrome, is an acute fulminating meningococcal septicemia usually associated with adrenal hemorrhage and purpura. The course is rapid and death occur usually within 24 hours. The diagnosis of meningococcal meningitis depends on the presence of the clinical manifestations as mentioned before and the investigations done for confirmations of the disease. The blood examination shows leukocytosis of about 20,000 per cubic milliliter or more. The CSF examination, which is the gold standard for the diagnosis of the meningococcal meningitis, it shows high opening pressure, the appearance of the CSF is turbid, the number of the cells in the CSF is very high, maybe 1,000 or more, and they are mainly polymorphinuclear leukocytes. The causative organism, which is the meningococci, may be detected in the CSF by the gram stain. The protein content in the CSF is high, the sugar and chloride contents is low. The differential diagnosis of the meningococcal meningitis include meningism, subarachnoid hemorrhage, and other types of meningitis other than meningococcal type. Number one is the meningism, which means meningeal irritations without meningitis, which occurs in children association with acute infectious diseases such as pneumonia. Here, the CSF shows high opening pressure but normal constituent. However, proteins and chlorides are somewhat low. The second type is the subarachnoid hemorrhage, in which the patient suffered from sudden onset of severe headache with no or mild fever. The patient does not look toxic. The CSF shows blood. CT brain show blood in the subarachnoid spaces. The third one in the differential diagnosis of the meningococcal meningitis is the other types of meningitis other than the meningococcal type. Number one is the tuberculous meningitis, and it is manifested by insidious onset, usually preceded by prodromal symptoms of malaise, high night fever, and night sweating and body weight loss. Signs of meningeal irritations are usually mild. Headache and vomiting are pronounced. The presence of the manifestations of the primary tuberculous focus in the body, for example, pulmonary TB. The typical CSF findings are diagnostic, and the CSF in the case of TB meningitis is manifested by high opening pressure, It has a characteristic appearance which is called the cloudy or ground glass on standing. The cells are mainly lymphocytes and the high number up to 500 cells per cubic milliliter. The proteins is high, sugar is decreased, chloride is markedly decreased. The TB bacilli could be detected by Zell-Nielsen stain. The other types of meningitis is the acute lymphocytic choriomeningitis. This is an acute benign viral infections of the meninges, choroid plexus, and rarely the brain substance. It's differentiated from the meningococcal meningitis by the presence of excess lymphocytes in the CSF, and it's differentiated from TB meningitis by the acute onset, the normal sugar and chloride content in the CSF, and the virus can be isolated from the CSF.